So as I said earlier, our Education Day today is centred on discussion around the fallout that we may experience after significant events. I'm a bit of a humanities nerd. I'm doing my Masters in Biomedical Ethics with some particular focus on ethical decision-making processes in critical care. And so today I'm going to talk briefly about the application of biomedical ethics in decision-making and reflection in pre-hospital medicine. My intention is not to teach ethics to this group. Ethical decision-making is already integrated into the practice of everybody here. But what I'm hoping to do is tease out some of these processes that we apply and the philosophy behind them and draw the topic out into the open a little and make it a bit more of a conscious and deliberate conversation. So the way that I'm going to do this, I'm going to present a case of mine that contains some common ethical issues encountered in pre-hospital medicine and generated some ethical challenges and reflection for myself and the paramedics I was working with. I won't be going into extensive detail as the purpose is not a dissection of the clinical details, but an overview to provide a basis for reflection. I'm also going to provide some brief background about the application of biomedical ethics in pre-hospital medicine with a focus on decision-making and reflection. Again, this is not intended to be a deep dive into philosophy, but to provide some grounding for the discussion. So this was a case I encountered during my last term with the service a few years ago. I've incorporated the perspective of a few others into this presentation, so hopefully I've done this justice. We were on an evening road shift and were called to a 2-car MVA where there was reported to be 2 critical patients. We were a 3-person team that day as one CCP was doing a ride-along, and we were at the scene quite quickly, around 15 minutes from the initial O call. The second road team on that day were offloading a patient and had been tasked to attend when they could. Around 5 minutes before we arrived, we heard over the radio that 2 patients in one of the vehicles had arrested, so they were being pulled out of the vehicle so resuscitation could be commenced. As a team, we collectively identified that we had 2 patients in traumatic cardiac arrest within a short time window, and we began to discuss how we would manage this, particularly how we would provide prompt and balanced care between the 2 patients. This was a decision point for us. Based on the info that we had, it was pretty fixed in our minds that our role would be to apply our TCA protocol when we arrived. So we arrived to a very challenging scene. We could see 2 very damaged vehicles and a busy scene with a large number of emergency services and bystanders. We received a brief handover that there'd been a high-speed MVA. 1 vehicle had rolled and the driver from this vehicle had absconded from the scene. It was mentioned at some point that he had allegedly stolen the vehicle, was likely intoxicated and driving on the wrong side of the road. And as I said, it's a bit hard to appreciate in the pictures, but there were people absolutely everywhere, all over the overpass and sort of watching all of this unfold. The other vehicle was struck right side head-on and contained 4 passengers. 2 were fined, 2 had arrested with ALS in progress. And due to this active resuscitation, there had been limited review of the patient's injuries at this stage. So we asked for barriers to be used to shield the patients from the view of the crowds and the police officers to try to clear the area. The 2 CCPs engaged with the crews and started delegating roles, explaining what the plan was, and they started to administer the blood. We had no info at this stage to differentiate the patients in terms of prognosis, so we gave 1 unit to each and ended up giving a second one to the patient that had less obviously catastrophic injuries after some time on the scene. My role was to do thoracostomies on both patients, and whilst doing this I ceased CPR and was provided with some extra information by the ICP managing the airway, including signs of injury in 1 patient that suggested that resuscitation was very likely to be unsuccessful, and this helped with later decision making. So this was obviously a significant and confronting case for all involved. We attended a debrief initially at the local station that night, led by a chaplain, and as is common for a hot debrief, this was focused on initial reactions, feelings, and the clinical facts. We summarised our respective roles and management and answered questions, particularly about the TCA protocol. A lot of the discussion was around the distressing nature of the event. It was an upsetting story with pressure of the spouses and so many bystanders on the scene. There were discussions about whether anything could have changed the outcome, with some hypotheticals discussed. Down the track, there was a follow-up debrief which was attended by the CCPs, and I heard about this recently when I returned to the service, as I'd been off maternity leave at the time. The later debrief was much more focused on ethical issues, issues around futility and decisions to cease care or even initiate care in situations where resuscitation ended up being futile or unsuccessful rather. We also reflected on this incident recently, and what stood out to us, this was obviously a very significant event for many people involved. There was quite an emotional impact that lasted for a while afterwards. It highlighted to us the challenges that can be present in ethical decision making in a pre-hospital environment and how this can be processed. So, I'm going to shift my discussion now to ideas and thoughts around clinical ethics in pre-hospital medicine. There is some literature on the topic, but it's not been nearly as extensively explored as the application of clinical ethics to other areas of critical care. What is consistent in the literature is that ethical tension is very common in pre-hospital emergency care, and it can be quite profound. And there are a number of reasons that it's often a very challenging context for ethical decision making. We often have less access to information about the patients to use to understand their preferences and backgrounds that may affect the decisions regarding their care. Pre-hospital providers often find themselves in challenging environments which can affect their ability to consult, engage with patients and gather information, and also affect decision making due to cognitive load. They work in ad hoc teams, including other healthcare workers who may not share their mental model or training in regards to ethical decision making, and they may need to rapidly shift their mindset from the provision of care to an individual patient to the care of multiple patients or a resource-limited context, which incorporates unique ethical issues around triage, justice, and our responsibility to society as a whole. Thinking about ethics is, of course, essential in critical care medicine due to the nature of what we do, and there's always an ethics-based discussion that could be teased out when caring for very unwell patients. The obvious reason that we would think about these processes in depth is because we would strive to provide a high standard of compassionate care, but it is also important for the well-being of ourselves and our teams to consider the ethical tensions that arise in our roles and how these may conflict with our morals, as these struggles can contribute to moral injury and psychological distress. The opportunity to address and learn from these is hugely important. Identification and improvement of barriers to ethical decision-making has been found to reduce stress and anxiety in healthcare workers, and research looking at structured ethical decision-making processes such as clinical ethics consultation and bioethics mediation can report reduced distress in providers engaging in these processes, and improved ethical decision-making skills in the future as well. So talking about how ethical approaches can be challenged in our work is essential to provide excellent care, but it can also be potentially comforting and supporting to us and our teams. So a structured approach to clinical ethics that most here would be familiar with is balanced principalism, which is the dominant ethical framework in clinical medicine. It was designed as a practical and simplified approach to clinical ethics that reflects common ideas of morality from several different theoretical viewpoints that may be considered to resolve ethical problems in healthcare. The principles are designed to be non-specific and broad and allow room for different interpretation of how they may be balanced to solve ethical tension in a given situation. The principles are that patients are given the opportunity to make autonomous decisions as long as they are able to do so, that care is provided in their interest and minimises the risk of harm to them, and that all people are treated fairly. But at times these principles can come into conflict, in part because they're drawn from different theoretical viewpoints and they prioritise different outcomes. In part they're drawn from duty-based ethics that assigns value to following rules, or moral rules rather, and on the other hand they're drawn from consequentialist theory that places value solely on the outcome regardless of the road taken to get there. And this is obviously a simplification of these theories, but as a result of bringing them together, there is often tension in medical ethics when these outcomes do not align. And so a common conflict, for example, is between principles of justice or fairness and that of autonomy. The original design was that these principles held equal value. However, as they come into conflict, there has been a desire for a way to sort between them or prioritise them. So it's common practice in Western healthcare systems for the principle of autonomy to be regarded as what they say is the first amongst equals, in that all principles should be considered equally, but respect for patient autonomy will take precedence when there is tension and decisions need to be made. And it should be noted that while autonomy is of primary importance in Western medical ethics, this is not universal across systems and cultures. So balanced principalism with prioritisation of autonomy works well in certain clinical environments, particularly during complex decision-making about individual patient care or case review when time can be taken to understand and weigh factors. However, in the pre-hospital context, and indeed in critical care medicine more broadly, we will at times need to consider the possibility of finite resources that are required for multiple patients. In these cases, we cannot prioritise the autonomy of everyone at once, and we need to consider these principles differently. So utilitarianism is concerned with the consequences of actions and assigns ethical value to actions that maximise good outcomes or well-being across a whole group, referred to as doing the greatest good for the greatest number. This approach applies well to public health ethics, as you can imagine, and situations where resource sharing needs to be considered more broadly. It's an approach that's often explained with an ethical thought experiment called the trolley problem that you can see here. It effectively asks if you would perform an action that results in the death of one person in order to save 5 people. A purely utilitarian approach would say yes, you would, and that it's the consequences of your actions that matter and not that action itself. But to contrast, duty-based or rule-based ethics would say that it is plainly wrong to perform an action that causes the death of one person regardless of the outcome. So an adapted approach to balanced principalism is utilitarian principalism, and this allows consideration of resource limitation and disaster scenarios. The idea is that when our responsibility is stretched beyond one patient at a time, then the principle of justice becomes paramount, which argues for the fair allocation of benefits and burdens, and that all individuals are treated equally. Individual autonomy is still valued, but not at the expense of others in the community. And this approach has been discussed and applied a lot recently during the COVID-19 pandemic, particularly during discussions around ICU bed capacity as a limited resource or debates around vaccination and obligations to society in terms of division of burdens. But even on a simpler level, this is an approach that we all apply routinely in critical care through the process of triage. So if we were to consider how the principles apply in our case, in hindsight, we assume that these patients wanted to be saved, and providing additional life-saving care would preserve their autonomy in that regard. However, as there were multiple patients and finite resources, we couldn't prioritise the individual autonomy of one over the other, and we sought to act fairly by dividing resources between them. Perhaps a little more complex is the consideration of benefits and harms. The whole team that night was acting quickly and with limited background and time for assessment, so we applied protocols that we expected may benefit these patients by saving their lives, although acknowledging that this was of low likelihood as the outcomes of pre-hospital traumatic cardiac arrest are often poor. There were potential harms associated with these interventions, such as compromise of the patient's dignity, exposure of the team and bystanders to graphic procedures, and physical risks such as Sharp's injury. However, the decisions were made to apply these treatments as the benefit associated with the possibility of saving these patients was perceived by the team to outweigh the harms, which we of course attempted to mitigate. It is, of course, very difficult to directly compare benefits and harms, as there is no prescription of the relative weights associated with different outcomes. It's not a straightforward arithmetic problem. Life-saving measures are, of course, of such immense benefit to the patient that these would certainly be weighted heavily. However, the benefit and relative weight of life-saving measures are very different in the presence of futility, and in such cases, the principle of beneficence would potentially argue against these measures. So one of the questions that I asked myself on reflection on this case was whether harm could have been avoided if I had made a faster assessment of the futility of the situation. I discussed this with several people at the time, and the conclusion that I came to was probably not in that situation. The whole team was of the impression that the patients had only recently arrested, and the imperative was to provide the extra level of care that I could quickly, which meant that I'd only provided limited visual inspection of the patients before I commenced. So I think that overall it is justified that we commence, and that was the conclusion of our team. But it is highly possible that a more experienced pre-hospital clinician would have processed this differently to me, or made a different assessment, or at least a faster determination. The assessment of futility is discussed a little in pre-hospital literature and regarded as a notoriously challenging area for the reasons discussed earlier, particularly the time-critical nature of care, limited information, and environmental challenges. Based on this, it is suggested in the literature that there may be a higher standard required to establish futility in the pre-hospital environment, particularly if this would result in the omission of potentially life-saving care which could have benefited a patient. As more research is conducted in the pre-hospital environment, there is more potential for evidence-based policies to guide what is medically non-beneficial care, and also appropriate termination of resuscitation and support ethical decision-making. So to consider how an evidence-based protocol may help with ethical decision-making in these situations, we can consider the TCA Protocol. This is a tool based on evidence to quickly identify and reverse potential causes of traumatic cardiac arrest. We use protocols like this as they help us to provide an expected level of care in a stressful situation. It has been developed in advance with deliberation of the potential benefits versus harms, and while applying protocols in critical care will not save all patients that they may apply to, they are designed to save as many as possible and are a utilitarian construct in this regard. Following a process such as this to quickly identify reversible causes also provides practical assistance in the assessment of futility or what is medically beneficial care. At the end of this process, the benefit of ongoing resuscitation can be reviewed with more clarity as we've worked through some potential reversible causes. So protocols might provide support in these scenarios, but sometimes they do not apply, or it can be challenging to decide when they should be applied at all. Quick decisions often need to be made in critical care roles, and a common criticism of principalism is that it can be challenging to apply quickly in these cases. I'm not saying that we can't ever apply principalism quickly, and we often do this intuitively when we encounter familiar ethical problems. However, there may be situations where it is difficult or impossible in a short time frame due to various challenges encountered in a job. So another approach is virtue ethics. This is an approach derived from the work of Aristotle, which focuses on the character of a person making a decision rather than the application of rules or consequences. It is suggested that a good person who acts ethically must develop certain virtues, which become part of that person's character through habitual use. Put another way, we aim to develop our character towards certain ideals that make us predisposed to do the best and right thing in each situation as much as we can. The rationale for this is you cannot memorise an ethical manual as such for every ethical challenge you may encounter in professional practice or life, and the capacity to respond to novel situations stems from what we can cultivate in our character. There's some really wonderful work on this topic in the emergency medicine literature about applying virtue ethics to ethical decision-making in EM, and this applies well to the pre-hospital literature also, particularly with so many of these character traits being well ingrained in emergency services culture. And as we'll discuss, this approach may provide support for reflection and when quick decision-making needs to be utilised. So the original suggestion by Aristotle is that a virtue lies in the middle of two contrary vices, with one being an excess and one a deficiency, and we're seeking a balance between these. For example, the virtue of compassion was said to lie between callousness and indulgence. These are some of the suggested virtues from the EM literature, and these are generally idealised character traits or virtues thought to be essential for harmonious teamwork and the pursuit of excellence in patient care. Some of these are ancient virtues from Aristotle's work, and one that comes up often is prudence. This refers to a practical wisdom or a basic common sense that is essential for the appropriate application of technical and moral facts on a case-by-case basis. It is needed for the rapid balancing of benefits and burdens, and indeed for moderating between other character traits or virtues. And this is obviously something that we all cultivate here through preparation and training, but also how we respond to experiences through processes such as reflection, debriefing, sharing the decision-making amongst our team or with a colleague so we can benefit from the prudence of others. And I won't go through all of these, which, as I said, are not an exhaustive list, but everyone in this room probably has their own idea or experiences in what character traits should be cultivated to perform this role in the way they think is best. The idea in the literature is that suggested virtues are given to inspire personal analysis, but not to necessarily be prescriptive of how people should be. So what does this add to what we already do? The idea is that virtue ethics is complementary to principalism, not a substitute, and provides us with a foundation for ethical-based decision-making and reasoning in novel and time-limited situations. Cultivation of particular character traits will help in how we choose, interpret, order, and apply ethical principles in the situations we encounter, and they provide a foundation for creative and adaptive solutions to novel and challenging situations. They suggest that when quick decision-making is needed, a form of ethical decision-making is to strive to act in accordance with the character traits that you most hope to exemplify in that situation. Also, this approach acknowledges the role of emotion and motivation in how we perceive and respond to these challenges. The approach of Aristotle was to suggest that we could find a balance between extremes, but emotions are core to many of the virtues suggested, which is reflective of our actual experience as healthcare workers. It is often impossible to dispassionately weigh and balance a problem in critical care medicine, as we are people with our own feelings, caring for others at very difficult stages of their lives. Because virtue ethics is focused on the agent rather than the act itself, it is suggested that this approach encourages moral agents to acknowledge the regret and distress that they might experience when navigating a challenging ethical situation. Just because the action can be ethically justified, it doesn't mean that there will not be emotional consequences for the people that made the decision. This picture here is from an exhibition running at the moment at the PA Hospital in Brisbane, which is featuring art by an RN named Kiralee West. She's a colleague of my sister and provided these for me to share. She interviewed health workers in ED to prepare for this project and said that a common theme amongst participants was that desire to have the human impact of their work acknowledged and addressed. The virtue ethics approach is certainly not for everyone, but it's something that works well with the way that I think, and I think it is a good approach to build upon how we consider ethical situations beyond principalism. So the EM literature describes actively applying virtue ethics to ethical decision-making by considering what virtues you would want to exemplify in addressing the situation before you. Sometimes, on a really basic level, this is described as imagining a mentor or someone you respect in your role and imagining what they might do. One author details a practical virtue ethics approach for decision-making in medicine more broadly, which involves considering facts, acknowledging the emotions that they triggered, and then considering what virtues or character traits you would most want to draw upon and how you would do this. So back to the case for conclusion. If we were to consider the virtues or character traits of a pre-hospital doctor that I would have most wanted to exemplify in that situation, it might help me to reflect on the decisions that I made and how I might hope to improve. I would imagine that prudence or practical wisdom is essential in making a quick assessment of the scene and what interventions are appropriate. And in the interest of patients and the teams, and particularly to support challenging decisions around medically appropriate or inappropriate care in the pre-hospital environment, I would try to optimise this skill in myself through using resources available to me, such as my experience, protocols, and importantly, the practical wisdom of those around me. Communication is an essential trait in this situation, and open and active communication about our plans and realistic expectations are essential in situations like this to minimise harm to others who may not be adequately prepared for certain interventions. Compassion is also essential. We need to ensure that we are acting from a place of genuine goodwill and desire to help the patients before us rather than other motives. These are just a few examples and could obviously be drawn out in detail with more personal reflection on my part. The outcome of the reasoning on this case is similar for me using a principalism or a virtue approach, but there is different nuance which can be reflected on by incorporating different methods, and this is what's done by clinical ethicists during structured ethical decision-making processes. So various people made decisions during the management of this difficult case that affected how this case progressed, and having an ethical discussion that is centred around the individuals making decisions and not the outcomes can also provide space to acknowledge the emotional impact that these cases might have on rescuers. So finally, how would we cultivate this in our practice? The literature suggests a lot of things that we already do here, which I think further highlights the value of team-oriented and reflective culture. They highlight the importance of consciously discussing ethics during reflection and as a focus of training in pre-hospital and retrieval medicine. And when doing this, it is important to acknowledge the impact that ethical tension and moral tension can have on us and our teams. Ensuring that protocols are evidence-based and practically useful help to streamline ethical decision-making by considering in advance how we can provide maximal benefit, minimal harm, and the greatest good for the greatest number. It could be suggested that cultivating virtues involves developing, supporting and fostering traits and creating work environments that support ethical decision-making. And finally, some institutions would utilise structured ethics decision-making or support services to facilitate decision-making or reflect on particularly challenging cases, and these can be of immense benefit when needed. And that's the artist I was telling you about in her exhibition, which is lovely. Thank you. It's time for lunch. So we'll come back at 1 o'clock. Oh yeah, of course.
So how would you integrate ethical discussions into copying cases?
I think so. Some of the things that were recommended is explicitly asking about ethics. So often it comes up as a bit of a side issue to discussions, but actually having a focused conversation and signposting it as we're going to talk about the ethical implications of it and do it in a structured way. So even if you apply principalism that we're familiar with, everybody knows that. And actually, it sounds a bit inane sort of when I talk through, but actually talking through those 4 principles and talking to the room about how they would balance those in different situations. Does everybody agree? It can be as simple as that, is my understanding.